from the American Academy of Pediatrics.
It's September, and that means it's almost time to vote for a new AAP President-elect.
Leaders in pediatrics must have an accurate view of the landscape of child health.
No entity is better suited to remind the country of the promissory note it owes to its children than the American Academy of Pediatrics.
But first, the start of a new month also means a content cornucopia from the journal Pediatrics.
I encourage everyone to read this article because it's really, truly inspiring. And I think it will give all of us ideas for how we can advocate for change in the community, not only in the area of gun safety, but in other areas as well.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with the September edition of First Up.
The house is so quiet now. School is back in session, so both of my boys are off at college, and it's just me, Christy, and the dogs.
Well, with baby, preschool, and first grade, the kids are back on a schedule, but the house feels really chaotic still, David. So I'm glad I have this podcast as an anchor to keep learning amidst the shifting needs of the 5 people living here.
Well, Joanna, it seems like you need some adult learning time, and I need another adult to talk to who knows what it's like to have older kids that are out of the house. So Dr. Rachel Moon can come back and talk to us both, the Associate Editor of Digital Media.
Ooh, for the journal Pediatrics. That means it's time for this month's First Up, where we review some of the latest articles in pediatrics. But before we start, Rachel, where are your kids these days?
Well, one of my daughters just moved to Oakland, and one of my daughters just moved to Philadelphia.
Yay! I did know that, but I don't think our listeners did.
Yeah, so it's been a busy summer for our family, but it's been exciting and it's all good things.
You know what else is exciting? The transition I'm about to make. I mentioned that I miss my kids, but did I say how much I love them? I love them so much that if one of them needed one of my kidneys, I would happily donate it. Living donors are one way that kids get kidney transplants, along with being placed on a wait list for a deceased donor. Children who get kidney transplants before they go on dialysis have better outcomes than those who don't. So, Rachel, do all kids have equitable access to early kidney transplants?
David, that is a great question. And unfortunately, no. But because we know that the outcomes are much better if the transplant is performed preemptively, which means before dialysis is started, and that children do better with living donor transplants, patients younger than 18 who are on the wait list for a kidney receive priority over adults, particularly at times when there are not enough donor kidneys. This is an important thing to know. However, it turns out that children who are Black or Hispanic are less likely to get a preemptive transplant or a living donor transplant. So Lindsay McClay and colleagues at Columbia University, CHOP, Dell Medical School, and the University of Colorado have an article in this month's issue in which they try to understand why there are these disparities. Is it that patients aren't getting put on the transplant list quickly, or is there something else going on? So they retrospectively analyzed data from a cohort of U.S. kidney transplant candidates who were placed on the transplant list between 2015 and 2019 when they were 3 to 17 years old. They looked at how long it took to get a transplant. They also looked at candidates who had started dialysis before the age of 18, but did not go on the transplant list until after their 18th birthday, because these were considered missed opportunities for this pediatric prioritization. About half of all of the pediatric candidates were put on the wait list preemptively. Patients who were female, Hispanic, Black, or who had public insurance were less likely to be put on the list preemptively. And maybe not surprisingly, 2/3 of those who were listed preemptively had no dialysis exposure before they got their transplant, which is great. But those who were not listed preemptively had an average more than 1.5 years of dialysis before they were transplanted. And then the ones who were not listed until after their 18th birthday had much lower transplant rates. So this is a huge problem. While the authors offer some speculation as to why there are these disparities, it's only that. It's only speculation. But these disparities have huge long-term consequences for these patients with regards to post-transplant outcomes. So I think knowing at least that there are these disparities, that's the first step, but it's hopefully not the last step in trying to fix this problem.
That was such a unique way to look at transplant disparities. And let's talk about another pediatric topic that unfortunately affects so many more children, firearm violence. Research has shown that firearm injury is the leading cause of death for children in the United States. We also know that state laws can reduce those deaths. So how can we as pediatricians advocate for laws that help prevent firearm injury and death?
This is something that is a huge issue, and we see this every day in the news. And in fact, Dr. Vivek Murthy, who's the U.S. Surgeon General, he has declared firearm violence in the U.S. as a public health crisis. So sometimes, even though we see this every single day and we see the direct effect of firearm violence in our daily work, it sometimes feels that change is impossible. And I know that I feel that way. And so if you feel that way too, I would strongly encourage you to read an advocacy case report, which is entitled Legislative Advocacy in Illinois for Firearm Injury Prevention by Dr. Deanna Behrens from Advocate Children's Hospital in Illinois and colleagues from Northwestern University and the Illinois AAP. Two of the authors, Dr. Deanna Behrens and Dr. Karen Sheehan, are pediatricians who worked with medical organizations, community partners, and legislators to get gun safety legislation passed in Illinois. So in this article, they and their co-authors describe their activities, which include building coalitions, crafting the language of proposed laws, developing public messaging campaigns, and then testifying to legislative committees. And importantly, the authors played key roles in both providing data about firearm violence in the state, including intervention models that could decrease the rates of pediatric firearm deaths. And then they also relayed stories about the personal impact of firearm violence. And this input was so important in the final bill that was passed by the Illinois legislature and then signed into law by the governor of Illinois. So I encourage everyone to read this article because it's really, truly inspiring. And I think it will give all of us ideas for how we can advocate for change in the community, not only in the area of gun safety, but in other areas as well, because so many of these ideas that they have translate into other areas where we can advocate for change.
Well, Rachel, you know that advocacy really speaks to me, and I hope our listeners are inspired now. Another thing that can get me excited is the introduction of new patient care technology. There's so many new ways for pediatricians and families to communicate, and this becomes especially important for children with complex medical needs who interface with their medical home frequently. Rachel, can technology make it easier for families and children with medical complexity to get the care they need?
I think that we're learning different ways that we can use technology. One of the things that is a huge area for children with medical complexity is in their care plan. So all children with medical complexity have a care plan, and this is a written document of the child's medical issues, their medications, and what their goals are for care. And even though the caregivers, who are the parents, the family members, the people who are at home every day with the children, even though they are the ones who know the child the best and are generally doing most of the care plans are generally written by healthcare providers, and the caregivers often have very little input into the care plan. So we need to come up with better models for transparency and shared decision-making for patients and families altogether. I'm a huge fan of this. And this month, we have an article by Dr. Clara Moore and colleagues from University of Toronto and the University of Washington entitled Caregiver and Care Team Perceptions of Online Collaborative Care Planning for Children with Medical Complexity. So the concept is really quite simple. The caregivers of the children who have medical complexity, they were given online access to their child's care plan on a secure HIPAA-compliant platform. And then they could make comments and edits to the care plan, and they could share it with other family members, or they could share it with healthcare professionals, just like they would with any shared online document. The authors then interviewed caregivers to ask them what they thought about this way of creating the care plan. And there were several common themes that were very, very interesting. So the first theme was trust. Caregivers in general made many fewer edits than anticipated. And it turns out that a lot of the caregivers didn't trust themselves to edit the care plan because they worried that they might make an edit that might be a problem. Like, what if they put in the wrong drug dose? And this concern was also expressed by medical team members. However, a lot of the caregivers did want to be able to identify changes that needed to be made to the care plan so that they could let the medical team make that change, or the caregivers wanted to know about any changes that were being made by the medical team. So this team suggested that there be some kind of a verification system where if the caregiver added any information, it would then be reviewed by a healthcare provider who could then press an accept button to allow those changes to be incorporated so that there would be this double check in the system. The second theme was responsibility. And this I thought was really interesting. The online care plan was seen as an additional responsibility and burden for the caregivers. While they appreciated the ability to give input into the care plan and thought that this demonstrated recognition of them as equal care team members, they also said that caring for the child took priority over everything else, particularly reviewing the online care plan. So then the third theme was access. Both the caregivers and the care team members appreciated that the online care plan was easily accessible, especially if there's an emergency situation. And caregivers particularly liked that they could access the care plan on their phone. So for instance, if they ended up in the emergency room, they could just pull up the care plan on their phone and show it to the emergency room provider. And then lastly, autonomy. Caregivers felt that the online care plan gave them more autonomy over their child's care, and both they and the care team members appreciated that this allowed everyone to be on the same page. So I think that the message here is that even though the comfort level among caregivers and care team members will differ, if we provide caregivers with the option to provide input and to have easy access to these care plans, I think that's an important positive step in improving communication, increasing autonomy, increasing partnership, and enhancing care for the child ultimately.
Well, Rachel and David, thank you so much for helping me exercise the adult part of my brain. Any last advice this season, parents, on how I can keep things organized for my family as the school year really starts to take off?
I don't know, Rachel. Do we remember how to organize things?
This is not inspiring a lot of hope for me, guys. I'm now seeing my lifetime of, disorganization stretching.
I will tell you that for our oldest, I dug through her backpack every night trying to figure out everything that was not getting turned in or lost or whatnot. And in retrospect, that was just way too much work. I don't think it made any difference at all.
You know what did help in our family? We made lunches the night before.
That is a great idea. Yes.
Yeah. And even when the kids were in elementary school, they were responsible for deciding what they wanted in their lunch and packing it. We would all pack it together. And it gives them a little bit of autonomy. And it also, they can decide if they want grapes or blueberries. And I think that that's a good thing.
Oh, yeah. What Rachel said.
And they may be more likely to eat it.
Oh. Well, Dr. Rachel Moon, thank you so much for joining us today.
Thank you for having me. I'll see you next time.
For these articles and more, visit our website at aap.org/podcast.
Coming up, we'll introduce you to the 2024 AAP President-elect candidates, Drs. Andy Racine and Lily Liu.
David, you might have noticed my social media posts urging people to register to vote and to show up at the polls.
Oh, trust me when I say I'm right there with you and really hope we have strong voter turnout in this year's elections.
That goes for national, state, and local elections, and an election that hits close to home here at the AAP.
Ah, yes, the election to choose the Academy's future leader, the AAP President-elect.
Every year, the National Nominating Committee spends months looking at potential candidates to slate and whittles it down to 2. Then those candidates run their campaigns in a series of statements, town halls, and videos.
It's a process I'm quite familiar with, and it's not for the faint of heart. The winner becomes president-elect and serves on the board for a year, learning the ropes from the sitting president. Then they take over as the face of the Academy.
This year, we want to use the podcast to help the candidates reach out to members. So we're going to play the statements of Drs. Lily Liu and Andrew Racine.
And in an effort to be completely fair, we're going to flip a coin to see who goes first. Okay. Heads is Dr. Lily Liu, and tails is Dr. Andrew Racine.
All right. If you're ready, David, I actually have a quarter.
All right.
Here we go. It's heads. So that means Dr. Lily Liu. Dr. Lily Liu is a neonatologist and director of government relations at the University of Illinois, Chicago. She's a member of the Illinois and Alaska AAP chapters.
She earned her MD at the University of North Carolina, Chapel Hill, and then did fellowship and served on faculty at Yale.
She's been in private practice in North Carolina and Alaska, academic practice in Connecticut, New Mexico, and Chicago. She's past chair of the neonatology section and past president of the AAP Alaska chapter.
Her role as chief medical officer for Alaska strengthened her belief that advocacy and health policy are key to improving the welfare of all children. I'm pleased to introduce Dr. Lily Liu.
Thanks for that introduction. My platform has 3 parts: inclusion, an effective voice, and bridging specific gaps. I'm a subspecialty section leader, a chapter leader, and a public health leader with personal experience in both academic and private practice. I value the unity and inclusion of all pediatricians, subspecialists and generalists, rural and urban, academic and private practice, researchers and clinicians. We must capitalize on the diversity of our membership and work synergistically. Providing leadership and development opportunities for all members is how we provide equitable and inclusive care for all children, families, and communities. Leaders in pediatrics must have an accurate view of the landscape of child health. This is key to having a more effective voice and a seat at the table in public health and health policy leadership. The AAP excels at developing advocacy skills. We need a similar strategy for public health and health policy leadership and sponsorship to marshal necessary resources for meaningful change. The AAP has been a leader in the rise of DEI in our national consciousness. We must understand the specific gaps so we can effectively target our interventions. These include geographic availability, dearth of particular subspecialties, social and political determinants of health, and of course, equitable payment gaps for pediatric care. To attract the best and brightest to the calling of pediatrics, we must assure health and sustainability for pediatricians. Quality demands ongoing research and implementation of best practices. We need strategic training of the next generation, including pipeline enhancement for the underrepresented. I hope to work together toward these goals within the Academy, our shared professional home.
Now I'll introduce Dr. Andrew Racine, the System Senior Vice President and Chief Medical Officer of the Montefiore Health System, Executive Director of the Montefiore Medical Group, and Professor of Pediatrics at the Albert Einstein College of Medicine.
Dr. Racine received his MD, PhD in economics from New York University and trained in pediatrics at the Boston Children's Hospital. When he returned to New York, he joined the faculty of Columbia University.
Dr. Racine has been president of Chapter 3 in New York, served on the AAP's National Committee on Child Health Financing, and chaired the National Task Force on Poverty and Child Health.
He was recently appointed to the Board of Trustees of the National Bureau of Economic Research and serves on the board of the New York Academy of Medicine. I am pleased to introduce Dr. Andrew Racine.
For years, the United States has chronically underinvested in the major drivers of child health: education, nutrition, access to clean air and water, decent housing, safe communities, and the health of children's caregivers. This underinvestment is an unpaid promissory note that this country owes to its children. Meanwhile, pediatricians are expected to rectify these deficiencies in our practices, which are overburdened with EMR documentation demands and struggles for payment. The health of America's children and the satisfaction we receive from clinical practice are both under threat. The good news is that this country has the wherewithal to rectify this, and no entity is better suited to remind the country of the promissory note it owes to its children than the American Academy of Pediatrics. Federalizing Medicaid with payment levels equivalent to Medicare, reinstituting the refundable child tax credit, and guaranteeing universal free preschool should constitute our comprehensive legislative platform. The AAP can also pioneer technologies that ease the use of the EMR, simplifying billing and enhancing payment. The AAP has a storied legacy of focusing this nation's attention on child health priorities. We did it with CHIP, we did it with the ACA, and we can do it again. We must marshal industry, government, labor, the media, and others in a united effort to reorient America's priorities, repurpose its resources, and establish a child health agenda worthy of this nation. As a health economist and general pediatrician, I welcome the opportunity to work with the AAP membership to craft and lead such an agenda.
Thank you to our excellent candidates. You can visit the AAP Election Center at aap.org for more information, or visit the podcast website, aap.org/podcast, for a link to vote.
Voting will begin on the 11th of September and close on the 25th, with results announced to membership on September 26th. Please vote.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, my youngest, Julian, decided to switch schools, and he now started college in Tennessee, my home state, in Nashville. And I checked in with him to see how he was doing, and Joanna, it took him 24 hours to find a honky-tonk and start two-stepping. This is a kid who's more comfortable in a mosh pit at a punk show, so I think the state is getting to him.
Ooh, I love country music. I'm excited to see where this goes.
Yeah, me too.
My Say Ah, I'll make about my son as well. As you know, he's 4, and we found out just recently that he got into a pre-K class in the school that his sister goes to.
Oh.
So now it's his school too. We can't just call it her school. But we're really embracing the Philly public schools, and I'm really loving that my kids are going to public school just like I did. I think it's really fun.
Me, all 5 of ours, it's delightful when he can make it work. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about necrotizing enterocolitis in preterm babies.
We'll talk to the chair of the AAP Committee on Fetus and Newborn, Dr. Eric Eichenwald. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.